Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. Subscribe at kevinmd.com/podcast. Today, we have a special sponsored episode from Loxo Lilly. We welcome Dr. John Pagel, Senior Vice President of Clinical Development and Global Head of Hematology at Loxo Lilly, bringing 25 years of experience as a physician treating patients on the front lines to a passion for researching treatments for blood disorders, including lymphomas and leukemias. Throughout his career, Dr. Pagel has served as the principal investigator of numerous protocols and has been involved in several other clinical trials. Today, we'll be discussing blood cancer seen through the lens of a researcher. John, welcome to the show.
Great to be with you, Kevin. Great to be with your audience. You're speaking to me about a subject that's really near and dear to my, not only my career, but my heart. So thanks for the opportunity.
So, John, can you briefly share a little bit about your story and your current role at Loxo Lilly?
Oh, yeah, sure. Of course. We all have a story. My story was an endeavor into blood cancers way back at the time I was a medical resident, which again was in the mid 1990s, dating myself, unfortunately. I guess the gray hair does that too. Sorry. But at that time, I was really becoming very interested in the science around blood cancer therapies and how we can help patients with novel treatments. Remember back not that long ago, the only thing that we had for patients, not just patients with lung cancer or colon cancer, but blood cancers too, all we had were a handful of chemotherapy agents, and that's all we used. And it was difficult on patients. And just around that time, I was a medical resident, was the idea of targeting blood cancer cells with a biologic therapy, and in particular, antibody-based therapies. We make antibodies in our own body, of course, to primarily fight infections. Those antibodies target those bacteria or viruses or what have you. Well, at that time, we were just starting to get into this idea that we could make these antibodies in the laboratory and that we could make them to target a cancer cell. And I was very turned on by the idea of actually using something that's not chemotherapy. And I started to go and look for an opportunity to do blood cancer research around these kind of new novel targets or therapeutics. And that kind of started a whole career of really developing drugs primarily in an academic setting, and now more recently at Loxo at Lilly, that are not chemotherapeutic agents.
So tell us, what makes you so passionate about blood cancer research and working in the hematology space?
Yeah, I think this is a really incredibly unique field, and I'm lucky that I've been able to be part of it, a small part, of course. I think the most important thing to recognize as a big picture is that with the therapies we have and the drugs that we've developed and continue to develop, we're really helping people. We're helping patients who have life-threatening illnesses. Like when I first started, as an example in this field, Hodgkin lymphoma was a lymphoma that killed more patients than who survived from the therapy. It is rare now for someone to die of Hodgkin lymphoma. And that's simply because the research that, has been done and that the opportunities that have been able to be explored have been, game changing, and that attracted me to this field. So I have been lucky enough to be part of those kinds of events in my own small little way.
Can you explain what causes B-cell lymphomas?
Yeah, like every cell in our body, these cells have a job to do, and blood cells have a job to do. And of course, people are well understanding that red cells carry oxygen. There's a blood cell called a platelet that's very important for blood clotting. But the majority of our blood cells are white blood cells. And white blood cells, their normal job is to keep us happy and healthy, to fight infections and keep us off of our kind of sick bed. It is true that with any cell, something can go wrong in the process of how these cells develop and grow, divide. it's just in many ways a random process. Sometimes, of course, there are external influences. We could talk about what could drive these things, but something goes wrong in the machinery of the cell. And that happens when it happens in white blood cells, it leads to diseases where those cells behave abnormally and in fact might be something we call a leukemia or lymphoma. So a little more way to describe that, Kevin, if you don't mind, is just to say these white blood cells are born in what we call the bone marrow. They're the long bones of our legs, our arms, the ribs, the skull. Mm-hmm. That's where these cells come from. And they're born there. And just like maybe your kids or my kids, when they were younger, they grow up. These cells become adolescents. It's time for them to leave the house. They leave the marrow and they start circulating in the blood. And they're looking for a profession. Of course, their profession is to fight an infection. So, they went to school for that. And they're looking for a home. And they like to live in what we call lymphatic tissue. So those are lymph nodes. The spleen is just like a big lymph node. And these cells hang out there until they do their job. And when they've done their job, which is, again, to fight one of those infections, those cells go on to become grandparents and then they die. And then the next cells come along and do their job. And that process just routinely happens. But again, as I've said, somewhere in that process of cell maturation, something can go wrong. And depending on where it happens, where something goes wrong, meaning that there's an error made, that cell gets, again, like my kids have been, arrested in their development, it leads to a cancer, a blood cancer. So if they get arrested in their development early on in that maturation phase, those cells now stop maturing. And I always think of this like those white stormtroopers in Star Wars, all marching exactly. They all look the same. And again, if that happens in an immature cell, that leads to diseases we call leukemias. And if that white blood cell happened to be a very, very, very mature cell, it often happens, and more often happens in that way, and that we call it a lymphoma. And every step in between will lead to a different subtype of these blood cancers. In fact, I think there's somewhere close to 80 different subtypes of lymphomas and leukemias. So it's not just one disease when we say blood cancers. Sure. But that's kind of the big story, how these cells become cancer cells. And hopefully everybody followed that.
Knowing non-Hodgkin lymphoma is the most common form of lymphoma, can you speak a little bit about the difference between Hodgkin lymphoma and non-Hodgkin lymphoma?
It's a really important point that it often confuses a lot of people. Hodgkin lymphoma and non-Hodgkin lymphoma are two totally different things. They're like apples and oranges. Yeah, they have the word lymphoma attached to them, but the mutations that lead to the arrestment of development and the clinical characteristics and how this plays out in patients are extremely different. Hodgkin lymphoma typically happens in young adults. So this is the 20-year-old who was off to college and feels a lymph node, and that's a disease that's rarely seen in adults of advanced age, although you can see a little bit of a peak in people that's in their 60s to get Hodgkin lymphoma. And then everything that's not Hodgkin lymphoma is what we call non-Hodgkin lymphoma. And again, that's where the 80 different subtypes come in. And I've mentioned some of those words: follicular lymphoma, large cell lymphoma, mantle cell lymphoma. Those are just not Hodgkin lymphoma.
So can you talk a little bit more about one of the subtypes of non-Hodgkin lymphoma, mantle cell lymphoma, and whom it affects the most?
So mantle cell lymphoma is just one of the more interesting subtypes of non-Hodgkin lymphoma that we address and think about. And it's interesting on lots of levels. We know that this lymphoma occurs because there are parts of two different chromosomes that break off and rearrange. There's a part of chromosome 11 that breaks off and part of chromosome 14 that breaks off. And those two pieces actually come together. And when that happens, it leads to a disease we call mantle cell lymphoma. It's not tremendously common. It actually only makes up about maybe 5% of all non-Hodgkin lymphomas. It's often behaved very aggressively. It is true that people often get chemotherapy for this lymphoma early on, and they get to a remission and they might do well, but they typically will relapse. The beauty of treating patients on, the provider side of mantle cell lymphoma is now we have a lot of arrows in our quiver, tools in our toolbox of what we can use for mantle cell lymphoma patients. And actually now we're seeing people that are living with mantle cell lymphoma for, 15 years, 20 years. And again, this is also recognizing the fact that this is primarily a disease of people who are a bit older. So these people have median ages where they get diagnosed in their mid to late 60s or even 70s, maybe even 80s.
What are some of the common symptoms associated with mantle cell lymphoma? And briefly share some of the challenges with the disease.
Yeah, I think one of the most important things to understand about this lymphoma is that people often will present sick.
Hmm.
They will have very commonly widespread systemic disease. In other words, multiple lymph nodes enlarged. Remember, these cells like to live in lymph nodes, and when something goes wrong there, they again get arrested in their development. They start making too many cells, and of course, then the lymph nodes get bigger and bigger. And they don't feel good. So they can be having fevers, sometimes drenching night sweats. And by the way, we all have these night sweats. What we're talking about when your doctor says drenching night sweats, they mean you're soaking the sheets, not just once in a while, like every night. You might be losing weight. Your body weight is dramatically falling off despite the fact that you're eating well. And these people often need attention and therapy relatively quickly.
Can you talk a little bit about BTK inhibition and why is it important for mantle cell lymphoma patients?
So this is really one of those reasons why I was attracted to having a career in blood cancer research and treating patients with blood cancers. Bruton tyrosine kinase is an enzyme that's critically important for the survival of these cancer cells. In our cells, we have all this machinery. They're proteins, or we also call them enzymes, proteins that are important for the normal functioning of the cell. And that protein BTK is important for the normal lifespan of a white blood cell. But something can go wrong in that cell where you can think of it this way, Kevin, that the light switch has been turned on and that you can't get the light switch off. And so the cell is just continuing to grow, divide, and make more of itself. And often what we're going to do is try and turn that light switch off. But in this case, that light switch is stuck. So the other way to turn the cell off is to cut the wire. And the way we cut the wire is we target that critical protein, Bruton tyrosine kinase, or BTK, that's inside the lymphocyte. So we actually cut the wire by essentially knocking out that protein.
You're listening to a special sponsored episode of the podcast by Kevin MD. Our guest is Dr. John Pagel, Senior Vice President of Clinical Development and Global Head of Hematology at Loxo at Lilly, bringing 25 years of experience as a physician treating patients on the front lines to a passion for researching treatments for blood cancers, including lymphomas and leukemias. What challenges do physicians face working in the blood cancer space?
Oh boy, I could give you a whole podcast on that. Well, I mean, listen, there's lots of different challenges, and you can look at them as if they're on the treating physician's end, or are they on the drug development end? I'll give a little perspective about both since I've spanned all that. On the patient treating side, the biggest problem that we have is getting the right therapy to the right patients at the right time. And that comes back to one thing I always say, and I haven't said yet here, but I'll say it now, is that patients need to be their own best advocate. They are the best advocate for themselves. Do your research, look at your options, talk to your doctor, ask hard questions. Physicians are never offended, in my experience, by second opinions. They're never offended by you bringing them ideas and other things to explore. Often, of course, physicians who are taking care of patients have a better handle of this than the physician themselves, but speak up nonetheless. As a patient, speak up for what you're curious about, what you want to know about, what your options are. Now, the other end of this, of course, is the development of novel therapies, new therapies for patients that are extremely challenging. We do a pretty good job in this way across the board, but you have to also, of course, remember is that this process takes a lot of time. So time from discovery of a drug through patients to actually approval and on the market can take, a good decade sometimes, depending on the drug, depending on the disease. So the challenges of developing drugs for these diseases is extremely big, and we need to continue to support that. We can do things well for patients, and we can do things well for pharmaceutical companies or researchers who are developing these drugs. We just got to figure out a better way to do it.
As a physician, what obstacles do you see most often that patients have to overcome in their journey with mantle cell lymphoma?
Yeah, that's a really interesting question. I think the obstacles are unique and perhaps somewhat different to each individual patient. But it's a commitment. It's a commitment to care. You need to find a physician that you trust and respect. And there is mutual trust and mutual respect. And if you're not finding that, you need to continue to look. Often it's hard to do all these treatments or any of this all by yourself. You certainly need support, not just from a caregiver, but sometimes even financially. And I will just say, explore the financial help that companies provide or foundations for cancer provide, and actually explore those opportunities like Leukemia and Lymphoma Society, Lymphoma Research Foundation, these important organizations that help patients address the challenges. And that might be ride shares to the doctor's office, which are plentiful if you go find them and get them.
And what are the most important things clinicians should understand about mantle cell lymphoma?
Well, yeah, listen, I could go on a whole podcast on that too. Most important thing is to understand that if something is not going well, listen to that patient and do something different. A lot of times, of course, we can separate ourselves as a physician from the patient and not know exactly what that patient's going through. We might hear the words, but they don't really touch us or resonate like they're touching and resonating in that individual patient. So I guess, Kevin, I think this comes back to my point around physician-patient interactions. It's mutual respect. It's working together. It's a two-way street on that. That's critically important for the best outcomes.
You're listening to a special sponsored episode of the podcast by Kevin MD. Our guest is Dr. John Pagel, Senior Vice President of Clinical Development and Global Health of Hematology at Loxo at Lilly, bringing 25 years of experience as a physician treating patients on the front lines to a passion for researching treatments for blood cancers, including lymphomas and leukemias. John, what are some of your proudest accomplishments as a researcher?
Well, listen, I think there's a lot of things that are near and dear to my heart that I am proud of that we can talk about. But I think the biggest thing I can say without question is the impact and the special relationship with patients who have life-threatening illness that I've actually been lucky enough to experience. People will often ask, Kevin, like, how could you go into this field? It's so depressing and it's hard. It's actually completely the opposite. This profession has allowed me to help patients at a level that, and to connect with patients at a level that, is really hard to find in any other profession. I'm super lucky and fortunate to have had that kind of opportunity to do that.
How would you describe the role Loxo Lilly plays in the blood cancer treatment space?
Yeah, listen, I'm very proud of what we're doing here at Loxo Lilly in blood cancer research. We are growing our blood cancer portfolio. Our approach is to focus on not the biggest drug always or what have you, but drugs that make a big difference for patients. We always are willing and wanting to tackle the difficult problem.
Two-part question next. What is a message you would like to give to blood cancer patients? And what is a message that you would like to give to clinicians?
Well, my first answer to the patients is never give up hope. There are tons of clinical trials out there in blood cancer research that might be appropriate. There are many trials that might be appropriate for each individual patient. Some might have multiple options for trials. Don't shy away from getting involved in trials, even what we call early phase trials. And people do make shifts in their care from involvement of these trials. And so don't give up hope. Hope is critically important, and it's there, it's real, it's tangible. And I know that it makes a difference if you can continue to kind of think about it and look at it that way. And then for physicians, I think it's kind of the same kind of thing. I learned a long time ago that I need to listen to my patient about what needs to be done next, much more than I probably need to tell them what needs to be done next. I can tell you times where I've heard from patients that they don't want to stop treatment, where I've thought that maybe they should, and I was wrong. So physicians shouldn't lose the hope, and they should listen to the patients. And I think, really across the board, that's what oncologists, cancer doctors in particular do. They're all in it for the patient. There's no other way to do this profession, in my opinion, if you're not all in it for the patient.
And my last question, John, just share some take-home messages that you want to leave with the Kevin MD audience.
Yeah, and listen, I think, you hear from me my enthusiasm for what's been done, but I hope you also hear that enthusiasm, but what's coming. We have now drugs that I hadn't even ever dreamed of thinking about 25 years ago. So bringing it all full circle, I think, let's continue to all, really engage, be actively involved, and continue to maintain hope and really provide outcomes for our patients.
You've been listening to a special sponsored episode of the podcast by Kevin MD. Our guest was Dr. John Pagel, Senior Vice President of Clinical Development and Global Head of Hematology at Loxo Lilly, bringing 25 years of experience as a physician treating patients on the front lines to a passion for researching treatments for blood cancers, including lymphomas and leukemias. John, thank you so much for sharing your perspective, time, and insight, and thanks again for coming on the show.
It's been great, Kevin. It's really nice to be with you. Thanks for having me.